Well, I'm here with Dr. Sam Goldhaber at Brigham and Women's Hospital, who is the lead investigator of the ADOPT trial, one of the late-breaking clinical trials at the American Heart Association meeting this year. This is studying a very key problem in medically ill patients on prophylaxis of DVT and pulmonary embolism. You've been studying this for a long time, Sam. Can you
Chris,
lay the groundwork for this?
Sure. Well, we have pretty well set what to do when a patient's in the hospital with an acute medical illness, such as congestive heart failure or respiratory failure or pneumonia. However, when a patient leaves the hospital, sometimes their risk of DVT or pulmonary embolism actually increases because they become less mobile at home without nurses to prod them or physical therapists. And we know that venous thromboembolism and death from venous thromboembolism actually increase during the 1 month or so after hospital discharge. So it's really one of the last frontiers for us to conquer in the field of venous thromboembolism. How do we prevent patients from suffering death or disability from DVT and pulmonary embolism after the hospitalization?
So in this trial, it was a large randomized trial. You had a standard arm of in-hospital low molecular weight heparin versus one of the new oral anticoagulants in-hospital and post-discharge.
Yes, this was a double-blind, double-dummy study. So when patients signed up to participate in the study, they were either receiving real enoxaparin for 6 to 14 days or a placebo injection, and then the other arm was receiving real Apixaban, 2.5 milligrams twice a day, or placebo pills for it, and this continued for 30 days.
Right, and so what were your findings?
Well, we hypothesized that Apixaban during the entire intended treatment period would actually be superior to the short course of enoxaparin by reducing VTE and VTE-related death. There was a trend in that direction, but it was not statistically significant.
Okay. How about on the bleeding side of things?
Well, on the bleeding side, there was more major bleeding in the Apixaban group. Most of that was a fall in hematocrit without any clinically overt bleeding whatsoever. And when one looks at the combo of major bleeding and clinically relevant non-major bleeding, there was no difference between the two groups. The bleeding rate was actually remarkably low in this trial.
So I guess from this, what would you see as the optimal treatment these days of a medically ill patient? I suppose a heart failure patient who has to sit around in the hospital for getting diuresed for a while.
Yeah. Well, for sure, we know that when you leave the hospital, the VTE rate increases. And this trial did not give us the exact prescription of how to decrease that rate, but it gave us a lot of important clues. I mean, for one thing, if you look at the event rate, you'll see after the parenteral treatment period is over, there's a sudden spike upward in the venous thromboembolism rate in those who were assigned to enoxaparin, whereas the Apixaban group actually stays quite flat for the rest of the 30 days. And I think the clue for clinical trialists is to really focus on enrolling patients at the end of the hospitalization rather than at the beginning, and putting all the emphasis on what happens from the day of discharge for the next 30 days.
Right. Okay, well, more focus, I guess, on high-risk patients. So
That's
congratulations
right. Thank you very
on
much,
a terrific
Chris.
trial. And for CVN, I'm Chris Cannon.